Okay, so the next talk is on early onset scoliosis. So this is a little bit of a different animal than adolescent idiopathic scoliosis, and it can, I'll say, lead to adolescent idiopathic scoliosis, but honestly, it's usually a different problem. Adolescent idiopathic scoliosis usually does not present before age 10. Usually these kids that you see, say, at 11 or 12 that have curvature did not have curvature when they were 6 years old. It's not something that was just missed or not picked up. They just didn't have it. Early onset scoliosis is different. Again, disclosures are listed here, none relevant to this talk. We will talk about some implants, and that's not to give preference to any implants, but some of these are worth discussing. So we're going to talk about some clinical findings, some associations with other body systems, and some newer treatment options. So again, this is much less common. This happens about 1 to 2 per 10,000 patients, as opposed to what we talked about in the last talk. It's interesting, it's more common in males. It's more common to be left-sided, and it's more common to resolve with time and growth. And so this is really the opposite of when we talk about adolescent idiopathic scoliosis, which we already said is much more common in females. It's usually a right thoracic curve, which is by far the most common pattern. It is highly likely to progress with age and growth, and spontaneous resolution is extremely rare. And I'm going to go back one to kind of just again reiterate that early onset scoliosis is typically the opposite, more common in males, more common left-sided, and it is more common to resolve on its own. So some clinical features of early onset scoliosis, you can see this very young child here with a significant rib hump right here. And so that is a significant rotational deformity that you may see. And so that can also present with an elevated shoulder, a trunk shift, those kinds of things where they're standing literally where their trunk is off to the left or off to the right because of the shifting of their curve. So some things that it can be confused with, one of those would be torticollis. So if you have a torticollis, which is in this picture here, where the chin is kind of pointed away from the contracted muscle and the head is tilted toward that side, that's a muscular problem. Most often, now there's other causes of that, but most often it's a muscular problem that resolves with time and physical therapy and some stretching exercises. And then the bottom picture is something called a Sprengel's deformity. And so that's where you have a congenital asymmetry of the scapulas. And so that left scapula on this child is much higher than it is on the right. And you can see here that that affects his shoulder abduction by bringing that left shoulder up not as far as the right shoulder, and that's called a Sprengel's deformity. And oftentimes that can be confused with scoliosis because it gives you shoulder blade asymmetry, which scoliosis does as well. And usually an X-ray will show you that in that situation, that child's spine is very likely to be straight or nearly straight as opposed to having a scoliosis. So what else to check? I think Dr. Walker, I'm assuming, will touch on this in his congenital scoliosis talk. But anytime you see a child, and I'll say for us typically under the age of 10, you would get an MRI of the spine. In a 12 or 13-year-old with a curvature, it's very rare to see spinal cord abnormalities in an adolescent idiopathic scoliosis. But in younger children, you can have about a 20 to 25% incidence of having something wrong with their spinal cord. So this arrow is pointing to what's called a syrinx, which is just an enlargement of that central canal with fluid. But you could see how, so fluid takes up space that the spinal cord should be occupying, and that can cause some issues with their neurology. Not always, but oftentimes it can. So what spinal cord abnormalities could we see? The most common is something called tethered cord. And as I've gone through, learning to treat scoliosis here over the years, I have become much more familiar with tethered cord than I thought I would be, as it's really a neurosurgical diagnosis. But the common presenting complaints are usually a constellation of constipation, which can also be bladder urgency, vague leg pain, leg tightness, low back pain. I put pain in car seats because over the years, we've kind of seemed to find that this is anecdotal, this isn't published or anything, but kids with tethered cord symptoms seem to have issues riding in a car seat for a long time. Now, those of us who've had kids riding in car seats might laugh and say, well, they always have problems. But in general, say more than 20 minutes, 25 minutes, and they're just itching to get out. They're crying, they're upset, they're unhappy, and they get out of the car seat and they're fine. So just something that I thought I'd mention to think about. So when it's diagnosed, we refer these to a pediatric neurosurgeon. They're the ones that actually treat the tethered cord with a detethering surgery if it's needed, and that usually solves those issues. If they have a mild curvature, a mild scoliosis, you can limit or halt the progression of the curve. If it's small enough curve, you can have it actually resolve over time, but at minimum, it does tend to stop the curve from getting significantly worse quickly. So what else to check? Sorry about the formatting here. This is a PowerPoint thing, but if it's congenital, again, we'll have a lecture on that later, but a renal ultrasound and an echocardiogram. And the reason is because those systems develop at the same time as the neural axis. So on the CT scan here, you can see what's called a hemivertebra. And that is something that Dr. Walker will talk about later on. So what do we do? What to do when we see these curves? Here's a child with a left thoracic curve here, and it's a mild curve measuring about 20 degrees or so. And so what we can do with that curve to start is we can simply observe. Okay, we can watch that curve. If that child has no other neurologic symptoms and is otherwise doing well, we can simply see that child back in 3 to 4 months for a repeat X-ray. And that can oftentimes resolve on its own. And so we'll watch it for a while to see if that happens. And so here's an example of one of our patients who came in with about a 25-degree curve, no neurologic symptoms whatsoever, a kind of a typical early onset curve, left thoracic curve, and over about a year and a half, it completely resolved. So now the natural history, here's a child with a much larger curve. And this is likely to progress with growth, unfortunately. And you can imagine this child at age 3 or 4 with already this size curve could lead to some significant deformity as an adolescent without any treatment. And the main thing would be interfering with pulmonary development. So if you see progression and you don't feel it's getting better, you can consider or should consider early control. That's either with a brace or a cast. So here's an example of a child that's wearing a brace, and that's designed again to control the scoliosis. Dr. Nixon will talk more about bracing in her talk, but that's definitely something you can do even in a younger child. And so this is an example of a type of a spine brace that we might use. And so it's basically a plastic shell with foam, and I kind of try to sell it as body armor. So if kids like Iron Man, you can kind of make it sound pretty cool that they'll wear this brace at least for a while. You can fool them a little bit, but it controls the spine during growth, but it's rarely curative. So it's not meant to be something to make the curve go away. That'd be ideal. Occasionally you see that, but in general, it's to try and control the curve throughout the growth period. And you get variable compliance with these. You can imagine trying to make a 5-year-old wear a plastic brace is kind of like making a 5-year-old wear a mask. That's going to happen for minutes at a time. So we have difficulty with compliance in young children. So a cast is non-removable. So just like I said in the last talk, you put a cast on a child's wrist. Sometimes that's better than a Velcro brace because it's non-removable. So it enhances compliance, and you can actually use it to be a little more of a dynamic treatment. And that's where we start talking about the concept of MEHTA casting. So this is Dr. MEHTA, and this started in the 1960s. So she developed a technique for casting of early onset scoliosis. So one of the very original techniques of casting, we relied on a 3-point mold, so more of a bending cast. You'd put the child in a trunk cast and bend the spine. And her thought was scoliosis is 3-dimensional, it's rotational. And so what she kind of came up with was a technique of traction, derotation, and molding of the cast to try and make the scoliosis improve. And so this is Dr. MEHTA. She came to Dallas when I was there and gave a talk, and you can see she was still very active, hands-on in putting these casts on. And so she's got the plaster all over her hands, and she's molding, and she herself has some pretty wicked scoliosis, but that hasn't stopped her from from this treatment. So we have a special table at Norton Children's that we can put the child in a little bit of mild traction and place a plaster cast, and that is applied with some stretching, some derotation, and certain kind of molds to help control the spine. And so here's a finished product. So the child is on the table right now, and they're padded up, ready to be casted. And here's just a picture of a finished product. Sometimes you can go over the shoulders, like in this situation. Most of the time we actually simply go from armpit to just above the pelvis. And this is a belly and chest cutout. And so obviously they need room to breathe, to eat, but the sides of the cast are still controlling the ribs and the trunk through that method. So typically we try and get the child to wear a cast for 2 to 3 months at a time if possible. Ideally, we would like 6 to 12 months of casting. Now that sounds pretty aggressive, and you really have to have some parent or caregiver buy-in for this, no doubt. You can use a brace for, say, a casting holiday. So maybe in the summer months, it's hot, they want to go swimming, they can use a brace to temporize that treatment. And what Dr. MEHTA really, her idea was to try and cure the scoliosis, and the studies that she would offer and the research that she did showed that in many instances, if started early enough, the scoliosis could actually be casted away. So here's an example of one of our patients. This is a 9-month-old girl that already has a nearly 30-degree curvature, and that progressed to at 21 months to the curve you can see here. And so a stretching x-ray on the right side shows that, boy, that curve is relatively flexible, it's pliable, so let's try casting. So it kind of goes to 41 degrees here on her stretching film. And so this was after 2 months of casting. And so here's her in a cast, in x-ray, that shows the curve down to about 34 degrees. And so we were making some progress there in the cast. And one of the things you can see over the pelvis is these molds that hold the cast in the right position over the pelvis. And so current x-ray at 4.5 years old, now again, it's still 54 degrees and it's not ideal, but nonetheless, it's still been controlled. Now, unfortunately, they get to around this age after a few years of casting on and off, and they're saying, well, I don't know if we can really handle this anymore. And so you say, well, that's not a very good result. Well, we don't know what it'd have been without the casting, and you can't really, there's a point to where the parents kind of will say, I think we're done with this treatment. And that's kind of what happens. So, but in the end, over 2.5, 3 years, we still have a decrease in the overall amount of curvature with the casting. And so there's some benefits to that. So what if that doesn't work? Some kids are too old, some curves are too large. Sometimes people just say, I can't do this anymore. I'm sick of my child being in a cast. We want to maintain the growth of the trunk. So usually by around the age of 8, your lungs are mostly fully developed as far as the actual number of the alveoli, which are the little air sacs that help with the oxygen exchange. Now they still grow in volume and size, but the alveoli are pretty much fully developed by around age 8. So if you do a fusion surgery like we talked about in the last talk, that's going to severely inhibit their pulmonary function. And so what do we do to control it without fusing? So we try and find some growth-friendly techniques. Casting is a growth-friendly technique. You're trying to control the spine and still allow them growth. So the next step, if that's not working, is growing rods. And growing rods are attachments or rods that attach at the top and the bottom of the curve. And they control the curve while allowing growth in between the top and the bottom. And so you're trying to do some distraction or growing of the spine, much like the original Harrington rod technique in many ways. And so this is just an example of a growing rod type of construct. You can see this curve is relatively high. It's fairly significant. So casting or bracing is not going to really control this very well. And so some instrumentation might be needed. And so typically we secure the spine above and below the curve with rods in between. So the whole middle of the curve is unfused, it's untouched. We really have 2 incisions, one at the top, one at the bottom, and snake these rods along the spine through the muscle without touching the spine so that it stays flexible and unfused. And so kids need usually a trip to anesthesia every 6 months or so to go find these connectors and distract the rods within these telescopic connectors. And so this can be concerning for developmental issues. There is some literature that may suggest that repeated trips under anesthesia have increased risk of behavioral or attention deficit type problems. So it's something that's being discussed, and it's something that a lot of us are at least aware of. In addition to that, we use live x-ray for these distractions. And so there's a lot of x-ray that these kids are subjected to, every couple times a year. So what are some newer solutions to this? So there's some different things we can try. Spinal stapling, spinal tethering, or magnetically controlled rods. And again, these are all in an effort to try and minimize the amount of surgery a child needs as they grow older. So spinal staples act as a clamp. This is a picture of this type of metal, usually Vitalium, that the staple is made of, that in ice or in cold, it has a kind of a normal appearance, but then when you expose it to temperature, such as body temperature or heat, the metal actually compresses. And so the idea is when you put these into the spine, into the body cavity, that they actually compress and can help tether or control the curvature as a child grows. And the problem with stapling is that a few centers that have kind of published these results seem to have some good results early on, and then as it became more available to the average person, they really weren't able to duplicate those results. So spinal stapling is still done, but it's really done more in some specialized centers that can seem to have better results than most people can duplicate. So it's really not a common technique across the country. Vertebral body tethering is something that's relatively new. Over the past 5-6 years has come on board. And so the idea behind this is a flexible tether as opposed to a rod. So these screws are put in through the chest wall. They're actually put in, say, to the front of the spine, which is different than those pedicle screws we talked about in the last talk. And so that now the cord is not able to be, you can't see it on x-ray, so that's why I kind of drew it in red. It doesn't actually look red on the x-ray, but it's a flexible cord, basically, that is clamped into these screws, and then with growth and time, it tethers the spine to try and improve the curvature. And so that's something that Dr. Walker and I are receiving training on. It's something that we're looking at. Again, it's still new enough that there's really not a lot of good long-term results. The biggest issue that most people have with the tether is, since you can't see it on x-ray, you don't know if the tether has broken. And that's something that's been widely reported as breakage of the tether. And the only way to see that is with curve getting worse. And so there's not a good way to know if your tether is still remaining in place or not. And then magnetically controlled rods. So these offer a telescoping design. And so the little purple arrow here is pointing to the area where the rod actually comes out of to distract the spine. And there's a magnet in here, which turns a mechanism which lengthens the rod. And you can see it lays along the spine. And again, it would be attached, say, at the top and the bottom of the spine. And the advantage to this is that you can do these lengthenings in the office. And so the trips under anesthesia, other than implantation of the rod, is much minimized. And so this, can make it a lot easier for kids and parents. And the in-office lengthening takes about 2 to 3 minutes. You put this controller on the back, you find that magnet, you push the button, and it distracts. And usually you can distract typically much more frequently, since you don't need to do that under anesthesia. And the spine typically grows in a child about 1 to 1.5 millimeters per month. And so every month every 2 to 3 months, we will distract the spine, let's say 4 to 5 millimeters at a time, which is not enough for them to feel it. It's not something that hurts them. It's not something that causes neurologic issues. It simply distracts the spine at a very small amount. So potential problems with this are some metal fatigue and wear debris. There's definitely some concern that as these mechanisms lengthen, that you have some wear debris from the rod. We don't know exactly the problem of having these microscopic metal fragments. We don't really know. Sometimes the rods, like any mechanical device, it can fail. The rod could be frozen. You can't get any more length out of it. You have to switch the rod out. It can fail. It can break. just like any device, that's an issue. So here's a child with a typical early onset curvature, a left thoracic curve. On traction, you can see how flexible it is. It's unbelievably flexible. And so these growing rods were placed at the age of 4. And so this was kind of an older technique we used to use with the end-to-end connector and attached at the top and the bottom. And so that's controlling her curve relatively well. As we go along, we exchange them to side rods. So you can imagine there's only so much rod that can fit in these connectors. And so every couple times we would have to actually switch out the whole rod because that connector was only so long. So then we move to side rods, which are these little connectors here. And this rod is all the way sitting up here. And so you have multiple lengthenings you can do before you run out of rod. So you get less rod exchanges. So at age 9, we exchange them to when she was big enough, you can exchange them to magnetically controlled rods. And so that's what you see here. Same fixation points, and her spine is still remaining relatively well controlled, and her thoracic height is being grown. And so here she is at age 13. She still has a curve of about 40 degrees, and her spine, as you can see here on these x-rays, where those rods have distracted themselves. And so from her initial x-ray to her more current x-ray, so she's retained nearly 10 centimeters of thoracic height, thoracic growth during this time, and she still has a smaller curvature than when we started. So in conclusion, there's a lot of treatment options for kids with spinal deformity, and we want to try and diagnose them as early as possible. So if there's ever any concern on physical exam or anything like that, an x-ray is rarely wrong. And that'll tell you if you have one of those other conditions like a Springle's deformity, or if you have a scoliosis, and early referral is very important. So I appreciate again your time and attention, and then we will stop sharing and see if there's any questions.